Hello, my name is Keaton Jones. I'm a clinical lecturer and HPB surgical resident at the University of Oxford in the UK. I'm going to talk briefly about HIFU in pancreatic cancer with a specific focus on immunotherapy. In terms of the role of high-intensity focused ultrasound in pancreatic cancer, specifically thinking about immunotherapy, I'll briefly touch on the immunotherapy cascade. I'll talk about the specific challenges in the context of pancreatic cancer, our experience conducting a trial here at Oxford, and our thoughts on future directions. So just going back to think about anti-tumor immunity and the immunity cascade, there are a number of steps which need to be completed in order for effective anti-tumor immunity to be effected. Now, starting with the release of tumor antigens, we need tumor-specific antigens to be released by the tumor. These need to be taken up by antigen-presenting cells in order to prime the immune system. Subsequently, effector cells, including T cells, need to be trafficked to the site of tumors, and then they need to infiltrate within the tumor structure itself. Only then can they recognize the tumor cell interface and affect their killing, and then thereby limiting tumor growth. This is where immune checkpoint inhibitors have their effect. Now you can see that if any of the preceding steps in this process aren't completed, then relying on immune checkpoint inhibitors for effective therapy is never going to work. Now within that cascade, there are some specific challenges unique to pancreatic cancer, which make it a very challenging disease process to tackle. Starting with the step one in the process, it's well recognized that pancreatic cancer has a paucity of tumor-specific antigens. And although other tumors with lots of environmental stimuli, such as squamous cell head and neck cancer and non-small cell lung cancer, is fairly susceptible to immune checkpoint therapy, this does not appear to be the case in pancreatic cancer. In addition, there's preclinical evidence that dendritic cells are dysfunctional in pancreatic cancer, failing in their priming of the immune system. It's well recognized that there's a very dense stromal reaction in pancreatic cancer with lots of extracellular matrix deposition, and this limits the extent to which T cells can traffic to tumors. Finally, we have an abundant suppressive immune cell population within most pancreatic tumors, comprised mainly of macrophages and myeloid-derived suppressor cells. And even those T cells which are able to traffic to within tumors are then deactivated by the presence of these suppressive cells and their subsequent stimuli, meaning they can't affect any anti-tumor immunity. And so deploying immune checkpoint therapy or other immunotherapies relying on T cells in pancreatic cancer as a monotherapy is going to be extremely challenging, and so far has not proved effective in these patients. Now, thinking about the potential benefits of HIFU in the context of pancreatic cancer, the ablative effect can have the benefit of releasing tumor antigens, and so step one in the process is already ameliorated. Subsequently, the tissue injury initiated by HIFU can cause the release of chemokines and cytokines from tumor cells, and this can aid in the recruitment of T cells. These stimuli, acting as a response to tissue injury, can also help to promote Th1 polarization and an immune response. And so those myeloid cells which were previously immune suppressive in nature can change their phenotype in order to become more of a pro-inflammatory cell population. And this in turn can promote anti-tumor immunity. Now, treating pancreatic cancer with high-intensity focused ultrasound is not new. There have been many trials conducted across the world demonstrating its efficacy, mainly in terms of pain relief in the palliative context. There's been limited evidence to suggest that it's effective at extending life expectancy. However, its combination with immune therapy is much less well studied, and certainly there are no trials to date demonstrating efficacy and limited preclinical data. With that in mind, here in Oxford, we wanted to satisfy the requirements of a phase 1 trial looking at the primary endpoint of safety, but also secondary endpoints, and importantly, including immune priming. We wanted to demonstrate that delivering locally ablative therapy in terms of high-intensity focused ultrasound was able to stimulate the immune system on a systemic level. And we're looking at this by looking at baseline bloods and bloods 2 weeks after treatment with HIFU therapy, in the context of pancreatic cancer, and we'll be conducting T-cell receptor sequencing analysis, as well as profiling any changes in other immune cell populations. Our trial workflow involves screening patients at the MDT, an MRI abdomen and ultrasound planning session before treatment approximately 2 weeks later, and this is carried out under GA. 2 weeks after that, after the treatment, we'll carry out T-cell receptor sequencing again, a further MRI abdomen, and then a final CT at 3 months. Now, you can see from our figures here in Oxford that we've had a very mixed experience in terms of trial recruitment. Whilst we've screened many patients, and there are some patients who've been eligible, we've had a high dropout rate later on down the workflow. So far, we've treated 4 patients, despite many more patients being theoretically eligible. I think it's interesting to share our experience for why these patients have been excluded in our hands. Now, first and foremost, in terms of the initial screening for the patient, when we come to look at the images, we see that many of the tumours involve other organs, which precludes treatment, arterial structures, and those patients are automatically excluded and don't go forth to have a planning session. And there was something that we didn't quite anticipate when we set up the trial, and that was that the MDT, in light of the recent developments in treatment of pancreatic cancer, particularly with FOLFIRINOX chemotherapy, had an overwhelming desire to get younger patients with locally advanced tumours through to starting chemotherapy as soon as possible. And so when we see patients in the MDT, we can get them started on chemotherapy sometimes in less than a week. However, with the HIFU trial, to satisfy the blood and also the imaging requirements, the planning session, and organise a treatment date for anaesthesia meant that we were often delayed by 2 or 3 weeks. And so whilst the patient may be eligible, there was a clinical rationale to try and push them forward to starting chemotherapy before they had the opportunity to start HIFU treatment. Finally, later on during the trial, during the planning sessions, we sometimes found that tumours were no longer visible on ultrasound, and sometimes this was associated with having had recent chemotherapy, and also highlighting the need for better treatment in pancreatic cancer. These patients sometimes rapidly progressed, and before we were even able to treat them, they became too unwell for treatment. This is just an example of an 81-year-old lady who had HIFU for a locally advanced pancreatic cancer. We can see pre-treatment scans showing a roughly 8-centimetre tumour in the body of the pancreas, and subsequently a significant reduction 3 months after treatment. So just lessons so far. We're only halfway through the trial here in Oxford, but lessons that I think are very important to share are that we've discovered that pancreatic body tumours appear to be much more favourable for treatment. Our workflow from screening to treatment needs to be tightened up, and I'm sure with appropriate planning and resources, that's achievable in any centre. It's important to recognise that histological material via endoscopic ultrasound is difficult to get and should be factored into any trial planning. And on a positive note, patients respond very positively to any HIFU invitations for treatment, predominantly looking at the possibility of having a one-off treatment session compared with longer periods for radiotherapy and chemotherapy. Looking across the world at exciting trials which are currently recruiting, there is an MR-guided HIFU trial for pancreatic cancer recruiting in the US, microbubble enhanced uptake of chemotherapy trial in Norway, and PanDox, which is a targeted chemotherapy using doxorubicin released by HIFU locally in pancreatic tumours, has just started recruiting here in Oxford. Also, on the preclinical level, hot off the press is a study published recently by the Professor Gail Terhaar's group in Institute of Cancer Research in London, demonstrating that combining immunotherapy with high-intensity focused ultrasound in a murine model of pancreatic cancer is effective at both prolonging life expectancy, but also recruiting those effector T cells to within the tumour microenvironment, which is a landmark discovery and pushes forward and demonstrates a rationale for combining treatment in future human trials. So just thinking about the way forward when it comes to HIFU and immunotherapy in future exploratory studies, I think first and foremost, we need to validate some of the preclinical data coming out with human trial data. It's important to think about expanding our treatable population. Our experience in Oxford demonstrates that there are patients who are unsuitable for HIFU treatment. But when you consider that the rationale for HIFU in the context of combining it with immunotherapy is there to simply prime the immune system, It may be that we recruit more patients if we focus on treating a proportion of the tumor or even a metastatic lesion rather than ablating the whole tumor. Dynamism in the approach to combination strategies. What I mean by that is that we have to bear in mind that there are conventional treatments that are going to compete with a trial therapy such as HIFU. And we need to be very dynamic and flexible in our approach, combining it either before, during, or after chemotherapy at some point. Surgical window trials will be essential in demonstrating histological endpoints, given the difficulty in gathering material from endoscopic ultrasound. And finally, very careful planning of combination regimens, taking sort of advice from looking at other trials, particularly with radiotherapy and immunotherapy, to think carefully about patient selection and scientific endpoints. Thank you very much.